Good afternoon, and welcome to this month's gathering of the Northern Virginia Health Policy Forum. My name is Jim Scott, and I'm President and CEO of Applied Policy, based in Alexandria. My focus and the focus of my colleagues at Applied Policy is to help healthcare organizations improve the lives of the patients they serve by helping them navigate the world of federal healthcare policy. We're pleased to host these gatherings promoting an exchange of ideas and approaches to the multiple issues that define healthcare today. The 2022 midterm elections finally ended earlier this week, giving Democrats a 51-seat majority in the Senate until Senator Sinema's announcement this morning. The House, of course, will be newly but narrowly controlled by the Republicans. Today, Representative Don Beyer is with us to provide an insider's perspective on what might be the focus of the upcoming Congress. Congressman Beyer will take his seat to begin his 5th term representing Virginia's 8th District. Congressman Beyer, who currently serves as chairman of the Joint Economic Committee, has in the past dealt with congressional brinksmanship concerning potentially exceeding the debt ceiling. With a stalemate potentially looming in the new Congress, Congressman Beyer is in a unique position to explain how the debt ceiling works. He has also been an advocate for expanded support of mental health initiatives. Additionally, his agenda will include fighting for further improvement in U.S. healthcare, focusing on broadening health insurance coverage for America's neediest populations. Finally, throughout the webinar, please type any questions you might have into the Q&A chat box in the bottom of the screen. We will do our best to answer your questions in the latter half of the discussion. Now I'll turn it over to Representative Beyer. Good afternoon, and thank you for being here.
Jim, thank you very much. And thanks to Applied Policy for inviting me to join this event. I'm also joined by Kate Schisler, who is my legislative director. I think she's invisible on this, but she's listening and hopefully will be commenting. And I adore Kate for many reasons, but among them is that she's among the, if not the most knowledgeable healthcare legislative aide up on Capitol Hill. It's really an important time to have this Northern Virginia Health Policy Forum because we're at an inflection point. We just finished the wildly successful 117th Congress. I'm so proud of what we've gotten done. The American Rescue Plan, the Infrastructure Investment and Jobs Act, which we call the Bipartisan Infrastructure Investment and Jobs Act, the CHIPS and Science Act, the Inflation Reduction Act, and much more. Just yesterday, we reauthorized the defense budget again, the National Defense Authorization Act, and very importantly, passed the Respect for Marriage Act, sort of reversing what we'd done with the Defense of Marriage Act almost 25 some years ago, and happily with many Republican votes. Joe Biden is likely to go down as one of the most successful presidents, really in memory. We've got to go back to Lyndon Johnson in 65 and 66 to have a Congress that has been as productive as this one. In interviews recently, I keep pointing out that no matter what happens in this 118th Congress starting on January 3rd, the stuff that was passed this year and last year will take some years to continue to unfold. Their effects will reverberate and resonate through the years. And when we think of it in healthcare policies, let me give you a brief snapshot of what we started in the 117th. First of all, the American Rescue Plan. That was the first big Biden bill, March 2021. It was the first big health bill, but it was the last of the big bills that was intended to rescue America from the pandemic, both the economy from the economic ramifications, and the American people from the immediate health impacts of the pandemic. It created a national testing strategy and included $160 billion for testings, for vaccines, and for a much broader COVID response, mostly emergency money to deal with the virus. I can't tell you how many people I know who have gotten 3 shots, 4 shots, 5 shots. I know there are sections of the American public, given states and stuff that are not in where we want them to be on terms of vaccines. And it tends to sadly be more about political views than healthcare access. But we've done a good job and still have more to do. We included $123 billion in that budget to help schools serve children and basically to reopen the schools. When I think when President Biden took office, only 8% of the schools were open. A year later, it was 99%. And it provided tax subsidies to a wider range of individuals and families who purchase health insurance on the markets established under the Affordable Care Act, who temporarily had their costs covered by COBRA because they lost their jobs. And then, they had to come back on and needed those incentives. And then finally, almost finally, we put a lot more money in there to incentivize states to expand Medicaid as allowed under the ACA. A bunch of states did it. It took a couple of governors, Terry McAuliffe and then Ralph Northam, to get Medicaid expanded in Virginia. But there were a bunch of states that still hadn't expanded. And we just put that money out there. Because as you know, the fear of the states that didn't expand was that the federal government money would be there at 95, 99% for the first couple of years and then perhaps disappear and they'd be stuck with the bill. So we're trying to overcome that reluctance. And last but not least, we had $3 billion, that's with a B, for substance abuse prevention and treatment and community mental health block grant programs. This in light of the more than 100,000 people that died of opioid overdose last year. And then the Inflation Reduction Act, we characterize it as the largest environmental bill in American history, all that it's done to electrify automobility and much more. But it also did a lot more in the healthcare space than most people realize. First of all, it's the first serious effort to tackle prescription drug prices. On average, Americans pay 2 to 3 times what citizens pay for prescription drugs. I lived in Switzerland for 4 years. I know, Jim, you've got Applied Policy's got an office in Basel. Everything in Switzerland was more expensive. It was $15 for a McDonald's hamburger. However, you went into the pharmacies, that was the one place where everything was almost free. It was remarkable, the difference between going into a pharmacy in the US and a pharmacy here. And part of that was the fact that Medicare could never negotiate drug prices, unlike the VA, unlike the private insurance companies. So the Inflation Reduction Act did 3 key things. The first, it capped the out-of-pocket costs for insulin for Medicare beneficiaries at no more than $35 a month for supply. As you know, you've read all the articles about the price gouging, the $700, $800 a month for insulin. In the relatively small cadre that thinks with something like 70 million Americans, or a third of, it's probably more than that, because a third of all adult Americans right now are pre-diabetic, with an A1C pushing on 7, that we need to be thinking insulin almost as a public good, equivalent to air and water and the like. There's 74,000 Virginia Medicare beneficiaries used insulin in 2020, a huge part of our population. So this $35 a month supply is a really big deal. And it was supposed to be an out-of-pocket cap for everybody. But because of the political process, and politics is the art of the possible, it's limited only to Medicare beneficiaries. But we've painted the picture. We know where we want it to go, is this cap should be for everybody. Republican senators chose to challenge the inclusion of the out-of-pocket cap for privately insured patients, defending pharma, basically. We had 7 out of the 50 Republicans voted with us, but we needed 60 votes, not 57. So we'll continue to work on that. The second key thing is it capped out-of-pocket costs for those with Medicare Part D prescription drug plan at $2,000, starting in 2025, and then indexed to Part D inflation in successive years. This is really important because many seniors with high drug costs were paying $4,000, $8,000, $12,000 a year in out-of-pocket prescription D drug plan prices, Medicare Part D. So $2,000 is really important. And as a part of that, the law also eliminates the 5% beneficiary coinsurance requirements above the catastrophic coverage threshold in 2024. So that's 1 million Virginians with Medicare Part D now have the peace of mind that their out-of-pocket costs are going to be capped. And finally, most importantly, number 3, it allows Medicare to negotiate high-cost drugs. We had done this in H.R. 3 earlier, back in the 116th Congress and in the 117th Congress, but was going nowhere in the Senate. So this 5 to 7 million beneficiaries each year use the types of high-cost drugs that would be subject to negotiation. So Medicare is not going to come in and negotiate every drug price. It's limited to a relatively few high-cost drugs. You target things that will make the greatest difference. And it's expected to save Medicare more than $100 billion over 10 years. So figure $10 billion a year. It's incredible cost savings. And if you figure the things that drive the budget deficit that some of us are concerned about are Medicare, Medicaid, and Social Security, this is a big step forward for Medicare. There are a lot of other meaningful provisions that will help reduce costs for Americans, but the takeaway that you should have is, although all this is going to roll out slowly, like the ACA, it's going to be transformative. And it's going to only become more obvious as each provision is enacted and as each provision is improved years to come. Let me pivot to the horizon, what's coming. Jim mentioned that we got a 51-49 Senate with Ralph Friel Warnock's victory. It's now a 50-49 Senate with Kyrsten Sinema being the 3rd independent to join Angus King and Bernie Sanders. She says she's not going to caucus with the Republicans. She probably won't caucus with us either, but apparently she never came to the caucus meetings anyway, so might not be that big a difference. The inside story, well, I don't know that I'm qualified to say the inside story. The inside obvious part is that she faced a very strong Democratic primary challenge in 2024. And figure it's December 2022, so that race has already started. And she had done enough to alienate rank and file Democrats. For example, we had included the elimination of the carryover provision for taxes for private equity, where you can use somebody else's money but still get the lower capital gains tax rate. She had got that eliminated. So Kyrsten's not made a lot of friends on the Democratic side of the aisle. So this may just be her thinking ahead to 2024 and the notion of running as an independent. But it's still going to be, as a Democrat, I still like the way it goes, because even with 50-49, instead of sharing power in the Senate, we will actually be able to name the committee chairs, control the agenda in the respective committees, and it will be a much better way to go. And in the House, they've got a very slim majority, 222 to 213 right now. And Kevin McCarthy's election as Speaker is, well, I don't want to say in doubt, but it's confused. He can only lose 5 votes, and there are already 5 Republicans who said they'll never vote for him. And another 7 who wrote a letter that showed up in the paper this morning saying, unless he does these half dozen things, they won't vote for him either. So we don't have a role in it except to watch. And this poor Kevin McCarthy, I don't think I'd ever say those words together, has to deal with this emboldened, burn it all down conspiracy chasing far right of about 20 folks to deal with within his own caucus. And that's, but he also has a lot of folks in competitive districts who want to win re-election in the presidential election year. So it's going to be fascinating for political scientists and us to watch the House in the years to come. In the healthcare standpoint, we hope that the chair of Energy and Commerce is going to be Kathy McMorris Rodgers. She's a conservative Republican, but she's smart and she's honest. And yeah, I think she'll do a good job there. And she's been on Energy and Commerce for a long time. There's a 3-way race for the chair of Ways and Means, obviously always critical for healthcare, among Vern Buchanan, a fellow car dealer from Florida, who's the senior person on the committee, Adrian Smith from Nebraska, and Jason Smith from Missouri. I don't know how that's going to turn out. I have my preferences, but I don't get to vote there either. However, the more thoughtful and reasonable people we could get to chair these committees, the more likely it is we'll be able to advance legislation, given the dynamic of the Republican Party. The most frequent question I get from journalists is, what are my anxieties about the 118th Congress? And I confess that they're relatively little. Obviously, I'd rather be in charge and help drive the agenda That's not going to happen in the House. On the other hand, with such a slim majority, I don't see them, and Democrats controlling the Senate and Joe Biden's president, I don't see them making any progress at rolling back the significant legislation of the last couple of years. The Inflation Reduction Act, the infrastructure bill, CHIPS and Science, the pieces of the American Rescue Plan that are still in place, and more. The legislation that's going to happen in the next 2 years is obviously going to have to be highly bipartisan, or it'll never make it out of the House or the Senate that still has the filibuster. And that it is what it is. And I'm pleased that I still get to do lots and lots of constituent service work, which even in the minority, there'll be 1,500 people calling with a passport that expired yesterday, or that need a hospital bed, or need an advice on this or that. So I don't think they're going to get much accomplished, but it's going to be a fun couple of years. I confess that among my political priorities is trying to recruit the very best candidates to take on the handful of Republican incumbents that seats we can win, or open seats. And politically, it's just to continue moving us in the direction of ever more healthcare for ever more Americans, and ever more affordable. So with that, Jim, that's a long overview, but I'd love to take your questions and try to provide some answers.
Thank you, Congressman. Based on your experiences, head of the Joint Economic Committee, can you please give us some insight into what the debt ceiling is and how it works?
An incredibly timely question, because with Democrats in charge for another maybe 2 weeks, we're supposed to adjourn next Friday, and of course we won't. We'll probably be back here in a couple of days after Christmas. There is a very, very narrow window to raise the debt ceiling now, while we still have the quote unquote power. I don't think anyone thinks that that's actually going to happen. So the debt ceiling, we're going to run into it on paper next September, but Treasury's warning us it could be as early as the end of June or early July. It's the statutory limit on the amount of total federal debt the government can accrue. And as you know, it's gone up quite a bit, especially during the COVID years, with first Donald Trump as president and then Joe Biden. So the debt ceiling is the legal authority that the federal government has to borrow the funds it needs to meet the existing obligations, Social Security, Medicare payments, everything else. And once we get to that limit, the Treasury Department has some short-term tools it can use, so-called quote unquote extraordinary measures. Like they can suspend the sale of certain government securities, but they can't do that for very long. Ultimately, they're going to run out of cash and they've got to borrow. It basically restricts the Treasury Department's ability to honor the commitments already made by Congress and by the president. So basically, we spent the money, and now we're telling them that up to a certain limit, they can pay for them, and after that, they're not allowed to pay. So Congress has raised or suspended the debt ceiling roughly 100 times since the end of World War II. Sometimes it's been a really clean piece of legislation that adjusted the debt limit. Other times it's in legislation aimed to reduce the debt overall. Other times it's just tossed into a must-pass bill, and you just not sneak it in there, but put it in there and it's got to pass. I'm part of the growing number of people that thinks we don't need a debt ceiling. It doesn't do anything. It's unnecessary. All it does is create a sense of crisis out there every couple of years, and much brinksmanship as people manage it up to the very last minute. Brendan Boyle, a member of Congress from Philadelphia, is the lead sponsor of legislation just to get rid of it completely. I am a very cheerful co-sponsor, and we will see how that goes. We're probably going to need to get rid of the filibuster before that actually happens, but we need to keep that vision out there. In the meantime, we've never not paid our bills. That would be a disaster. It would jeopardize the whole full faith and credit of the United States. It would crash the cost of our debt, because the AAA bond rating would go way down. In fact, it went down in 2011 when they had to stand off from AAA to AA+, and that actually cost us, the taxpayers, an extra $1.3 billion a year just because of that brinksmanship. So it's very unserious exercise, political gamesmanship, which is why we should get rid of it. But we will see what happens in the days to come.
So thank you for that. The closer deadline is the expiration of the continuing resolution that you referenced. Um, what sorts of year-end healthcare legislation do you think might be part of that?
Um, well, let me firstly give you the timing standpoint. If you asked 100 members of Congress, you get 98 different opinions on what's going to happen with that. The hopeful perspective is that sometime between now and January 1st, we will pass the omnibus bill that funds the government for the next, next 9 months, through September 30th. We're getting begging from the Secretary of Defense, the heads of all the armed services, and basically anybody that tries to manage the government to please don't put us on a longer continuing resolution. When you have a continuing resolution, you're basically telling the managers of government, whether you're a four-star general or the head of NOAA, that we don't know what your budget's going to be. Keep using last year's until we tell you different. And as a consequence, nobody can really make a decision. It's even dangerous to go with last year's because you don't know whether the budget's going to be cut. It's a craziness. It's like, sending your husband to the grocery store to buy stuff and not telling him how much money he's allowed to spend. And so the hope is that we'll pass it before the end. Right now, the two biggest appropriators on the Senate side, Pat Leahy, who's been there, elected in 1974, the last of the Watergate babies, and Richard Shelby, are both in their 80s and are both retiring, and they're the two most important legislators. So all of us hope that they don't want to leave with a continuing resolution. In the meantime, we're $25 billion apart, and the Republicans don't want to come up 25 billion and the Democrats don't want to go down 25 billion. By the way, as always, we've passed it in the House. The House has come to an agreement. It's the Senate where the problem exists, and we will see. In terms of specific healthcare legislation, there's a lot on mental health care in the omnibus. In fact, it's the biggest healthcare investment that we've ever made, which we really want to come out, including what we very much hope for is the first campaign on the suicide lifeline. Jim, as you know, and probably most of the people on the call know, that the lifeline changed from a 10-digit number to 988 in the middle of July. It was a 500,000 call increase just in the month of August as people began to understand that 988 exists. But my guess is that 80% of the American public still doesn't know. And we need to tell them, and the number of lives that we will save on that are really important. Another thing included is long COVID. With Jack Bergman, a Republican from the Upper Peninsula, he and I have been leading in the House, Tim Kaine leading in the Senate. And we have 7 to 20 million, depending on what number you believe. That's the range the New York Times gives us of people suffering from long COVID today. 2 to 3 million who aren't working because of long COVID, who are out of the workforce. And we need much, much more work to really get deeper into long COVID and to figure out not only how to prevent it, but how to bring people back from that. Poor Senator Kaine still suffers virtually every day, all day from the long COVID effects. And then we're about to reintroduce a bill on all-payer claims databases to create state all-payer claims databases to allow for the collection of federal claims. This is just the most important data tool that we could create in a long time. So, yeah, there's much, much more. And when you get a bill the size of the omnibus, we could probably talk for an hour just about the healthcare provisions in that, so. And all the things that aren't in it yet that need to be.
Well, thank you. And then looking ahead to the upcoming term, what do you want to get done? Perhaps that you got started in the past Congress but didn't finish.
On healthcare alone, Jim, or just overall?
Overall, ideally, some of
Yeah.
it's healthcare.
Yeah, well, whatever, John Katko, a Republican from Schenectady, he and I formed the Suicide Prevention Task Force 6 years ago. He's retiring. We'll find another great Republican, somebody like Chris Stewart, to do it with me. We want to continue to go down that road. We have 47,000 Americans die by suicide last year. I think roughly the same number this year. Anything that we can do, like the 988 number or the suicide campaign. We have a barriers bill, which is authorized but not paid for, to look community by community to a net on a given bridge, or getting rid of that attractive nuisance telephone pole, places where people have been successfully or dying by suicide in the past. I think we obviously want to continue on the whole maternal mortality. It's been a big issue on Ways and Means. It's very sad to see how high our maternal mortality rate is compared to most of the other civilized countries in the world, and specifically by demographic. Black women's maternal mortality is something, 3, 4, 5 times higher than it is for white women. And we got to figure out why and what to do about it. How much of it is prenatal health care? How much has to do with other environmental factors? The pieces that I personally are probably be most engaged with and I'm excited about are number one, and forgive me for getting nerdy here, but the Fusion Caucus. That, as we still look at climate change as the greatest existential threat to humanity for the balance of this century, when we're on track to 2.7 degrees centigrade, not 1.5 by 2050, we need to get off fossil fuels as quickly as we can. And while we're making great progress with lots of renewables and with better technology, fusion energy, which has been a dream for 90 years, is many very good physicists and entrepreneurs think that we could do it on the grid by the early 2030s, sort of 2035 at the latest, that there will actually be actual fusion reactors by 2025, 2026 that show that fusion is working. Lawrence Livermore Labs last week showed for the first time more energy out than energy in, which is the magic breakthrough that people have been waiting for almost a century. That can replace almost all fossil fuels and allow for the electrification of all of our vehicles, the electrification of our homes, a cheap, the fuel is water and there's no radioactive waste. It's the holy grail for poverty reduction and for climate change. And if my team and I just work on that, that will be fulfilling and sufficient. But a second thing, I'm very committed to, as I chair the Joint Economic Committee for the next 21 days, the centerpiece this last 2 years has been income inequality and wealth inequality. And to that end, we have introduced a baby bond bill, which would overcome the multi-generational absence of inherited wealth. Jim, as most of us know, the best way to get rich in America is to inherit it. So if you're in a family, especially a relatively new American family, that has nothing to inherit, never owned a home, for example, the baby bonds would create a savings account for every American child at birth, and then add to it based on family wealth. So that at age 22 or 25, not for a big trip to Tahiti, but rather for a graduate education or start your own business or, buy that first house. It would help overcome the multi-generational gap in wealth. Quick statistics, the average Black family in America is 1/8 the wealth of an average white family. Average Hispanic family, 1/6 the wealth of an average white family. And that's for lots of reasons, including centuries of discrimination and disadvantaged housing policies and much more. And then on mental health treatment, and Jim, as you and most of the listeners know, we seem to have an unparalleled epidemic of anxiety and depression among our young people, roughly measured 13 to 30. Something that high school and college counselors, they say they've never seen anything like before. We don't have enough psychiatrists. We don't have enough psychologists. It's expensive anyway. By the way, as a quick parens, one of the things included in the omnibus is the extension of telehealth that was authorized in the American Rescue Plan and back in earlier COVID legislation. Telehealth has been a godsend for so many Americans. We don't want it to go away. We want to make sure that the interstate restrictions are unnecessary and needless. And it's been a very powerful way to deliver therapy to lots and lots and lots of Americans, especially kids and younger Americans. Among the initiatives that we're working on, Kate Schisler on this call has been leading the effort, is peer-to-peer counseling. If you don't have enough psychiatrists and psychologists and guidance counselors, you still have smart college kids who can be there for their roommate or their friend that is having trouble. And so what are the standards for training peer-to-peer counselors? How do you certify them? What training do you give them? How do you just create a cadre of caregivers, much larger, if not as sophisticated than the one that we have right now, to get us through the tough spots? Again, one of the things we know from 100 years of psychotherapy is the most important thing is just to be there. To be a good listener. But there's lots more, and we'll keep pushing.
We have a question from our good friend Shane Doucet, who wants to say, thank you for your vote for the Law Enforcement De-Escalation Training Act a few weeks ago. And even though it passed the Senate, it did not make it past the House. So do you think this bill can make it over the goal line before the end of the year?
Shane, hello. I wish that it could, but I don't have any optimism that it will. First of all, I've not seen it even scheduled on the House Rules Committee. I love the bill, and it goes hand in hand with a lot of what's happening here in Northern Virginia. We got earmarks for the first time last year. 10 last year, 15 this year. All 15 we applied for are in the omnibus. One of the reasons we want the omnibus to pass, because if it doesn't, we have to start over again next year. But one of them is to build a special mental health unit as an adjunct to the Arlington Police Department. We know that relatively few of the cases police have to respond to involve needing weapons. And a lot of them are people in a psychiatric emergency, either contemplating suicide or just having a psychotic break. And that's where the mental health team can make such a big difference. That's part of the de-escalation. I'm very proud of our Alexandria police. The last I heard, something like 90 of them had taken mental health first aid training, which is a great thing for our police officers who are always in a difficult situation to have. So the de-escalation bill is a really good one. We will continue to work, try to make it happen, but it's very plausible that it will be something for the 118th Congress.
Thank you. And then turning back to healthcare, another question from the audience. Are affordable healthcare options for self-employed and small businesses and their families part of the healthcare accessibility discussion?
Yes, very much so, especially, one of the things that I believe is in the omnibus, 96% sure, is pumping up the amount of subsidy and credit that we give for the ACA premium payments, basically cutting the size of the payments, because they're still ridiculously expensive. I just look at it personally. I'm a 72-year-old member of Congress with my wife on my health insurance, and it's $19,000 a year just for the two of us. And that's partly because it's age rated and I'm 72. But it's, and that, by the way, has some kind of congressional subsidy in it, I think. I don't know how much, but if it's $19,000 with help, can you imagine what it would be without? So that makes it unaffordable for so many, many, many Americans. So anything we can do to bring down that cost. And this would be especially true for the self-employed and the small businesses who don't have a lot of choice but to go on the exchange.
Then, thank you. Another question from the audience is, physicians face significant Medicare payment cuts in 2023. This causes issues for healthcare providers in midst of a workforce shortage. Will Congress do anything before 2023 or in the coming years to address these cuts to physician payments?
Yes, and that again is in the omnibus. it's not a full restoration, as Jim, as you know, as probably as most of the healthcare advocates on the call know, that the word always jumps out of my head. Forgive me, word retrieval at 72 is a tiny bit harder. One of the kick-ins that forces us to cut the physician thing, I think it was by 4% this year, and 2% of that 4 is restored in the omnibus. But we need to restore all of it. And once again, we keep moving in the wrong direction. It makes it ever harder for physicians to make all the numbers work, which then has lots and lots of reverberations, including the concentration of these small practices within hospitals, the fights over site neutrality, which affects orthopedics and oncologists and many other issues. And there's a lot of pernicious things going on in the healthcare industry that are being driven by how the payment stuff works, including the constant push to cut reimbursement rates for healthcare professionals.
What do you perceive to be the biggest challenge to achieving, you outlined a number of healthcare priorities and things you want to get done. What's the biggest challenge to achieving that healthcare agenda?
This is going to sound very partisan, but I think the biggest challenge is the filibuster in the Senate. Because you have to get 60 votes right now, it makes sure that almost any legislation is relatively anodyne. That it can't be bold, because boldness does not characterize the Senate to begin with. And it certainly doesn't characterize it when you have to get 60 votes, which is why if you look at the things we got done this last time, the Inflation Reduction Act, the American Rescue Plan, you had to do it under reconciliation, which you can use once or twice per session, which is the rule by majority. So I think that would be the biggest single problem. The second biggest problem is that, our federal debt, used to be that was one of the biggest things that we worried about. No, it rarely even comes up. It takes almost a very conservative Republican or a blue dog Democrat to point out that our federal debt's now greater than our GDP, which used to be a totally frightening prospect. There are people, the modern monetary theory, you think, well, it doesn't make any difference, but there are still, I often quote Herb Stein, the old economist, who says, if something's too good to be true, it's not true. And that sooner or later, we need to be concerned about it. So you back up and say, why is the federal debt so high? It's not because of discretionary spending. What we spend the $750, $800 billion on non-discretionary non-defense, and roughly the same on defense, is the smallest part of the federal budget. We're now pushing 80%. That's either Medicare, Medicaid, Social Security, or interest on the debt. And interest on the debt obviously is going to be a lot higher because of what the Fed's doing. So grappling with those in a responsible way is very, very difficult. And if we could do that successfully, that would then take the pressure off and allow us to be more expansive, care for more people, care for more healthcare costs on the spending side. The thoughtful person would say, yeah, well, how do you do that? There's been a wonderful bill around for years called Social Security 2100, led by John Larson, who's from Hartford, Connecticut, that makes Social Security secure through the end of the decade. Joe Biden's White House wouldn't touch it because it has a 0.04% increase in the payroll deduction tax per year over the next 25 years, which is to say invisible. But it would make it Social Security there for our kids and our grandkids who don't believe it will be there, and takes 1/3 of the problem away. And then, Jim, I turn to you and all the people on this call to figure out, how do we restrain the increases in Medicare and Medicaid costs? And I would say that there are a lot of ideas out there. I mean, telehealth was one small, important idea. The notion of getting away for fee for service and onto the per capita model is another idea. Let's keep people healthier. I know, I don't want to cite an apocryphal number, but one of my friends in pharma pointed out that of the 17% of our GDP we spend in healthcare, 3 to 4% of it is just obesity related. So that's something that doesn't need to be built in. Well, imagine if we address the obesity crisis in a responsible way in this country, what additional money that would free up. Or let me just pivot, 20 to 25% of Medicare costs. Remember, that's one of the big three drivers of the federal budget. 20 to 25% is just end-stage renal disease, which is to say dialysis. Where does dialysis come from? It comes from type 2 diabetes. Where does that come from? It comes from obesity. Dial it back. There are things that we could do that we present with very different Medicare and Medicaid profile and help us save a lot of money. One other idea, as you drop the Medicare, or as you expand Medicaid, you make Medicare more cost effective because people aren't as sick when they get to 65. Or as you drop the Medicare age from 65 to 64, for a while there, we had it going down to 58. Once again, people are healthier at 65 because of the healthcare they got at 58, and the burden will be less expensive. Or if we can find a breakthrough on Alzheimer's, when you figure 50% of Americans that hit 85 will have some degree of Alzheimer's, the healthcare cost that we are looking at there should frighten us all. And again, we look at policy and pharmaceutical breakthroughs to help us manage all that.
Thank you. So we got a question from the audience. The transition to value-based care has received increasing attention. MACRA established a 5% incentive payment to encourage participation in advanced alternate payment models. However, this incentive payment expires at the end of 2022. Are there any plans to address this?
I don't know, Jim. That's a really great question. And Kate and I will note it and take it back. There's still hope in small letters for a tax extender policy at the end of the year coming out of Ways and Means. That would be the perfect place for extending that MACRA incentive. But I have not seen Chairman Neal of Ways and Means schedule a markup on the tax extender bill, which means it may just get kicked to the next Congress. It's got to happen because the tax extenders affect so many different people, so many different businesses. And these are all things that should be permanent, but the political machination is to do it once a year and kick the can down the road. But that's the right place to do this, I think. And by the way, I heartily endorse it. I certainly know with my wife and my kids, the healthier I can keep, we can all stay today, the smaller the healthcare burden down the road.
When COVID happened, there was a public health emergency declared that in the healthcare space extended a lot of flexibilities to providers and states. But now that it seems that the public health emergency is ending, at least officially from the federal government, many people may be kicked off states' Medicaid coverage. Is there anything on the horizon to address the many people who could potentially lose their Medicaid coverage?
Well, there should be, but I don't know specifically, other than us at the federal level continuing to pour money into Medicaid expansion. But that's really the larger question, Jim, is there were a lot of relaxation of regulations and rules, especially on things that across state lines, for example, during COVID, that may kick back in. And I think we need to look really critically and say, was there a downside? And if there wasn't a downside, let's preserve the relaxations that we had during COVID and make sure we're not moving backward or in the wrong direction. And certainly throwing people off of Medicaid, it's got to be very short-sighted, very foolish. People on Medicaid are going to provide, not only will their lives be better and they will be healthier, but they will be a lot less of a burden on the federal budget and state budgets in the years to come because of it. It's I think I'm still the only certified auto mechanic in Congress. And when you're fixing cars, there's an old rule: it's pay me now or pay me later. but you're going to pay me, and it's always going to be more later.
Well, thank you very much for that. That's about all the questions we have time for, but Congressman Byer, I'd like to know if you had any final thoughts and takeaways for our audience before I wrap up.
Jim, my one takeaway is optimism. I feel, well, first of all, I was really thrilled to see that the election in November was a return to normalcy, to borrow from Warren G. Harding. That the crazies didn't win in both parties, and that really pleased me. And I think the next 2 years will be interesting. They probably are not going to be nearly as bold or progressive as the last two, but we'll still be moving forward, I think. And there's so many exciting things on the rise. And I mentioned fusion. I won't go on more about that, but that is very exciting. Everything is happening in healthcare. CRISPR and what that's going to do to genetic diseases, mRNA and the fruit of all the vaccines, all the research that's being done in this country and around the world on healthcare. And just advances in machine learning, et cetera, et cetera. These are great times to be alive. And whenever any of my friends or family get sick, I point out that there's been no time in human history when you wanted to be sick better than today, because of all the things that are going on. So I just think we need to wake up every morning and do the best we can and be optimistic about our future.
Well, thank you, Representative Byer, for joining us today and for the great discussion. And thank you also to our audience for joining us. As an important reminder before I close, Applied Policy has a monthly newsletter that discusses timely healthcare policy topics. A review of this will be in there. To receive our newsletter, you can find a link to the chat to join our mailing list. We'll also send the link in a follow-up communication to our attendees. And lastly, we'll be holding our next Northern Virginia Health Policy Forum on January 11th, and we'll discuss expanding hospice care with a patient and caregiver advocate and a key CMS decision maker. We hope you can join us, and thanks again to Congressman Byer, the Applied Policy team, and all of you, our audience.